I'm at the Dementia and Neuromental Health Unit here at UQCCR with Dr. Nadika Dissanayaka. First of all, I want to thank for her for this opportunity to share my work. So this work is part of my PhD. I'm now addressing reviewers' comments for thesis, so fingers crossed that I'm not too far from getting it all done. So today's talk, I'll be discussing identification of mild cognitive impairment in Parkinson's disease and moving on to task-dependent fMRI study on Pdmci using attentional network. So Parkinson's disease is the second most common neurological condition here in Australia, but remains one of the least understood. Over 70,000 Australians are now living with Parkinson's, and of those, more than 17,000 are currently living in Queensland. And including their families and caregivers, this disease impacts over 700,000 Australians. You might already know that this is a progressive neurological condition, that over 82% of PD patients are over the age of 65 years. And if you imagine someone in Australia is diagnosed with Parkinson's every 47 minutes, which is quite a shock. And with the increasing life expectancy leading to growing elderly population, it is quite important to understand the disease and broaden our knowledge. So you typically imagine Parkinson's patient with their motor symptoms such as stooped posture, masked facial expression, tremor, muscle rigidity, and shuffling gaits. They are well recognized by clinicians, and symptomatic relief with medication is quite well established as well. However, there are a wide range of non-motor symptoms such as cognitive impairment, dementia, sleep disorder, depression, anxiety, and so on that are quite difficult to identify, undertreated, and complex. Therefore, the concept of Parkinson's disease has progressively changed over time from motor disease to complex brain disease. So I'm particularly interested into the cognitive aspects of Parkinson's. So approximately 30 to 40% of patients show cognitive impairment even at the time of their diagnosis, and with average 42.5% of patients experienced mild cognitive impairment, so-called MCI. The terminology first derived from MCI in Alzheimer's disease. So the concept of MCI is basically to identify patients who are at risk of developing Parkinson's dementia. Many studies have reported that PD with MCI has a higher risk of developing dementia compared to those without, and there are other reported risk factors such as age, gender, severity of disease, disease duration, and education. Yet the longitudinal studies have reported varying progression of MCI to PDD from 62% in 4 years, 26% in 5 years, 50% in 7, and 83% in 20 years. So these inconsistent rates are possibly due to unstandardized diagnostic criteria for Pdmci and different cognitive phenotypes. When you think of Alzheimer's disease, you'd relate to memory loss, like not remembering things or forgetting things. However, when you think of cognition, it is not just memory. There are other cognitive functions such as visuospatial function, including visual discrimination, spatial judgment, perceptual organization, attention and working memory with alerting, selection, sustaining attention and shifting attention, language with object naming, word finding and fluency, executive function with planning and decision making, as well as memory. So the main basis for Pdmci is to first have a diagnosis of Parkinson's disease with a decline in cognitive ability, no interference with functional activities, no dementia, and no other mental disorders. So at first, the concept of MCI derived from the MCI in Alzheimer's disease. So in 2005, by Pdmcr group, recommended subdividing MCI into amnestic versus non-amnestic, which means memory. Later in 2012, the Lipman et al. Suggested it is important to assess all 5 cognitive domains, including memory, attention and working memory, executive function, language, and visuospatial, then explore whether it is single domain or multiple domain Pdmci. The recent criteria lists 2 levels, the abbreviated level 1 with global cognitive assessment, which can be administered in a short period of time, and comprehensive level 2 criteria with assessing at least 2 tests per cognitive domain. And MCI is diagnosed when patients score below their previous score, estimated pre-morbid levels, or appropriate norms using 1 to 2 standard deviation cutoff. So if patient fail 2 tests from one specific domain or 2 tests across any other domains, they will be considered as MCI. And here are the list of cognitive assessments that we administered for our study for 5 cognitive domains, and this whole package took approximately 1.5 to 2 hours per participant. So in our sample of 79 PD patients, the frequency of MCI was 34%. Despite previously reported risk factors, our sample did not show significant difference in demographic, including age and education, except for gender, where Pdmci had more male patients. The PD-related measures such as disease duration, medication level, and disease severity did not differ between the 2 groups, as well as neuropsychological measures, including anxiety, depression, and apathy. Using global cognitive scales such as MMSE, MoCA, and PDCRS, Pdmci patients performed significantly worse in all 3 cognitive testing than PD without MCI. So this highlighted that our sample was well characterized, and cognitive impairment can be seen as a sole symptom that is not in relation to any other factors. As I discussed before, the heterogeneous characteristics of Pdmci was also observed in our dataset. Deficits in memory, executive function, and attention working memory were common. As you can see in this graph, that Pdmci patients who had impairment in 3 or more domains all had impairments in executive, attention, and memory impairment. Patients with impairments in 2 domains were commonly observed, and again with a mixed combination of those commonly observed cognitive deficits. So just by observing this graph, you can see that understanding Pdmci is very challenging because of this heterogeneity. Taking this further, our next aim was to use task-dependent fMRI to identify the neural basis for deficits in commonly impaired cognitive domain. So here is the task that we administered during the fMRI scan, called attention network task. So participants were holding a button presser on their dominant hand and were given an instruction saying, please press left point finger when the central arrowhead points left, please press right point finger. When the central arrowhead points right, please respond as quickly as possible. So I'll quickly play this video so that you can follow. So as you can see, this is a very simple task where you press the button depending on the direction of the center arrow, as you can see here. So it is expected that the reaction time for congruent condition, where the arrows are all pointing to the same direction, will be faster than incongruent. Q condition was also given at the beginning with no Q, center Q, and spatial Q. Spatial Q will tell us where the arrow will appear up or the bottom. So the reaction time for spatial Q will be much faster than center Q, and then no Q will be the slowest. So with this, the task allows us to observe into 3 different attention networks, including alerting by calculating no Q minus center Q, orienting with center Q minus spatial Q, executive control with incongruent minus congruent. So the overall reaction time was significantly longer in PD patients with MCI compared to PD without MCI and healthy control. Also, PD without MCI was slower than healthy control. The overall accuracy again demonstrated that Pdmci and PD without MCI were much worse than healthy control, but there was no difference between the PD subgroups. However, looking into 3 attentional networks, there was no behavioral difference was observed in all 3 calculations for alerting, orienting, and executive control between the Pdmci and PD without MCI. Despite no behavioral difference, when we took it further and examined the fMRI data, we observed difference in the brain activity during alerting, which is the difference between no Q and center Q. Firstly, we observed a downregulation of left postcentral gyrus here in the right side of the graph, where the downregulation of left postcentral gyrus observed in Pdmci compared to PD without MCI and healthy control. This was an interesting finding because faster rate of cortical thinning of left postcentral gyrus was also previously reported in Pdmci group. And also we found overactivation of cerebellum crus 1 in both Pdmci and PD without MCI compared to healthy control, where it is previously reported to be related to cognitive processing, specifically in sustained attention. We also found increased activation in the cerebellum during resting, where participants were asked to close their eyes and think of nothing. That the activity between medial prefrontal cortex and cerebellum M6 was significantly higher in Pdmci compared to PD without MCI and healthy control. So the cerebellum is known as little brain that is comprised of 69 billion neurons compared to 16 billion neurons in the cortex. It coordinates voluntary movements, modulates cognition and emotion. So this part of the brain is technically helping the bigger part of the brain to work as smooth as possible, which in this case can work as compensatory mechanism to prevent the brain from failing. However, studies have reported that this compensation may disappear once patients develop dementia. So more studies are needed to understand the specific brain regions or mechanisms that help the brain to compensate so that they exhibit normal cognition, and to identify its impairment once patients develop dementia. To do so, it is important to further understand the fMRI markers for early dementia by investigating the role of cerebellum in Pdmci, focusing on specific cognitive deficits, doing longitudinal studies, or other brain imaging analysis such as structural dynamic connectivity or other tasks. So today I have shared importance of targeting subtypes of MCI in PD patients. Task-dependent fMRI studies can provide details of more specific deficits in Pdmci. And lastly, future studies on other cognitive domains. So that, and we are currently working on a study focusing on memory impairments. So here is a list of people who have contributed so much for this project, including my supervisor, team members, and members at other facilities who have made this project possible. And that's pretty much it, and thank you for listening.
Fantastic. Thank you very much for that, Julia. Let's open this up to questions. So let's see. Please just sort of unmute yourself and ask your question.
Can I speak?
Yeah, go for it, Sonia.
That was great, Julia. It was really, really good to see your work all summarised so succinctly. Just a question for my own education, I guess. It seemed that in the little graphs you displayed of the classification of MCI, there were 3 patients. I wasn't quite sure what the y-axis was, but it looked like there were 3 patients that only had an aphasia, essentially, so deficits in the language domain.
Yes.
But that they received an MCI classification.
Yes.
Wow. Okay. Cool.
So what for classification of MCI, what we did was they had to have a impairments in any 2 tests across the 10 cognitive assessments that we perform. So, for example, for this person with 3 patients with language deficits, they had failure in 2 language assessments, and they were all fine in the other spectrum of cognition.
Interesting that it's classified as MCI. I think those working in the language field would think of that as a classic aphasia, but interesting of the different methodologies. Thank you.
Thanks, Sonia. Other questions?
Sorry, it's Nadia here.
Yes, go ahead.
Hi, Dave. I'm sorry to join a bit later. I had a bit of drama this morning. But Sonia, just to follow up that question, so what Julia has applied here is the standard classification for MCI based on the Movement Disorders Society criteria. So this language deficits here, it depends on the test that we have used. There's a number of verbal fluency tests, and we use the test based on DCAFs. So it's sort of standard classification process, and people can fail in 2 of the tests within this just specific language domain to be classified as MCI. So that's how it's sort of been done. I'm happy to talk to you a bit more about it if you have a bit of doubt in terms of, is this actually the MCI classification or not? It's quite an interesting comment, and thanks for that.
Yeah, no, that'd be great to talk about that. I mean, Julia made it really clear the criteria she used, so I'm not criticising that in any way. It's just obviously interesting from my perspective that there's this crossover in terminology and definitions.
Certainly, thanks.
So Julia, I guess a big question, a personal question for you. What's sort of next steps after your PhD is accepted and you're ready to go out into the real world?
Yeah, so I'm working closely with Nadika for like expanding this project as a basis. So we are currently developing a clinical trial for treating memory impairments in those Pdmci who have a greater memory deficits.
Mm-hmm.
So we are trying to relate that with a functional MRI and any types of brain imaging that we can maybe look into a bit more further. So I think there's a lot of work to do in terms of like clarifying how cognitive deficits is impacting Parkinson's patient, because it's not so clear at this stage. So I'll be very interested to dig this more further.